Dr. Johnson is a graduate of Mercer School of Medicine and completed a family medicine residency at ETSU. He was in private practice in Hiawassee, where he was a founding member of a 3-physician group providing full hospital, nursing home, and clinic care. He's board certified in family medicine, palliative medicine, and integrative medicine. He currently practices integrative palliative care as a medical director of Erlanger Palliative Care, and he's active faculty member with the University of Tennessee. I'd like to thank Dr. Johnson for taking time out to give us this talk, and I hope we can all welcome him. Thank you.
Thank you, Lou. I got to turn on my mute. Good morning, everyone. Thank you for coming. Glad you're here. I hope you'll end up being glad you're here. The handout that you got is a kindergarten worksheet. I mean, it is so easy, you could do it with your eyes closed. I'll tell you why it is so easy at the end of the talk. I would invite you to fill in the blanks as we go. You'll be glad you did once you find out why you have the kindergarten worksheet. Right? So it's not difficult, but it is valuable. So it's a lot like palliative care. It's not difficult, but it is valuable. So why would you want to get them involved? Well, everybody says we're all going to die. And everybody knows we all got to go sometime. And most people say that if the end of their life were really nearing, quality is more important than quantity. It's like the old saying, I'd rather die while I'm living than live while I'm dead. One physician told me, if the bourbon has to go down the tube rather than being able to be swallowed, that's it for me. And that was his advanced care directive discussion with me. He looked me right in the eye and said, I'm quite serious. If you're on service and they're talking about putting bourbon down the tube, that's it for me. Okay, I said, I got it. We just had a goals of care conversation. Wasn't that easy? And you know how nobody wants to be that clinician who the family says, well, what they did or what they recommended took quality or quantity away from my loved one. So those are the reasons that you might want to get serious illness care involved. And that's basically the talk. The good news is we'll just explode that a little bit for the next 20 or so minutes, and we'll have a fun little thing at the end that will help you and help me, and you probably get out of here a little early. So let's see. So my guess is there are days when your clinical world feels like this to you. And you know, am I pulling my head off? Did I just pry it out of the sand to find that, oh my, the rest of me is not with me? I mean, there's just a dozen ways to think about this wonderful picture. Really like that one. So serious illness care is really simple. It's about focusing on quality of life during the course of a serious illness. And ideally, it happens concomitantly with life-prolonging care. All right? You may have already found a fill-in-the-blank on your kindergarten worksheet. Serious illness care focuses on blank quality of life during the course of a serious illness. You don't have to write it down. I promise it won't hurt my feelings if you don't. But if you do write it down, you'll be glad you did in the end. Palliate simply means to lift the burden. That's what the word means, and to lessen the burden. And that can be any variety of burdens. That can be pain or vomiting or fear or anxiety or insomnia or constipation or all of the above. It's a wide spectrum of care, and hospice is just a small, distinct expression of a larger umbrella of palliative care, right? That's where hospice fits in. It's the last sort of final common ground of palliative care. We help people with a serious illness. This is the key summary. If you could get this in your head, and if you were going to get serious illness care involved, and your patient said, well, why should I let you get them involved? You can say, because they help people with a serious illness live as well as they can, as long as they can, on their terms. Now, I don't know if that is on your kindergarten sheet, but you may want to write that down, because that is as succinct as it gets. It took me years to get it boiled down to that point, all right? Live as well as they can, as long as they can on their terms. Dr. Stone, is that hard to say? It's easy to say, isn't it, Saba? I mean, it just rolls right out once you start singing, doesn't it? So, as well as they can, read symptom burden relief. That's what you mean when you say, can help you live as well as you can. We're going to relieve some of your symptoms. When you say, as long as you can, read alongside aggressive treatment. I'm not talking about withholding care from you. I'm talking about adding care to you. Extra layers of support. Things that the rest of the clinical team may or may not have the time, energy, or training to do. On their terms, read goals of care conversations, advanced directive forms, advanced care plan discussions. I mean, just what's wrong? I mean, that's all good, isn't it? The whole thing. In the sink, driving the boat, styling. That guy's okay, man. But if you've ever felt like you're, out there in your clinical world, you were trying to take a bath in the sink because there's just so much coming at you. This is one of my last cheerful slides before things get a little sad. Here we go. These are the facts of life. Death, actually. 20% of everybody you know and love is going to die suddenly and tragically. It's been happening for eons. 20% of people on the planet today will not be here at the end of the day, and they will die suddenly and tragically. I hope it's none of us. Sometimes I hope it's none of us. Because the alternative, the other 80% of us, will have an extremely predictable, can see it coming miles away, slow decline death. For example, if you have widely metastatic cancer, this is what your trajectory is likely to look like. If you're going to die from that cancer, you're going to do really well for a long time. And then you're going to sort of drop off the cliff. That last little segment there is typically about the last 90 days of a person who has widely spread cancer's life. They just precipitously drop off. So if you're not going to choose to die suddenly and tragically, and you're not going to choose to die from cancer, because, there's just only two doors out, 20%, 80%. You get to pick which door you're going through. I told a guy one time, I said, I'd like to talk about your goals of care and what's valuable to you if you're facing the end of your life. And he said, look, I know that there's an afterlife, and I know where I'm going. I know which line I'm standing in. I just don't want to cut in line. And I said, Tom, I get that. I'm worried that you might be closer to the front of the line than you think you are, and we should talk about that, right? So if you're going to pick organ failure, like heart failure or COPD, this is what it will look like. You'll muddle along, you'll get admitted. You'll muddle along, you'll get admitted. You'll muddle along, you'll get admitted. And everybody other than your clinicians will think that you're doing fine. Well, we do this all the time. What do you mean we should talk about goals of care? We admit Tom all the time. This is the 5th time this year we've admitted him for heart failure. Everything's fine. Unless you start asking them, well, when's the last time Tom could mow the yard? Well, after the first time we admitted him this year, he couldn't mow the yard anymore. When's the last time Tom could help with the clothes? Well, after the 2nd time we admitted Tom, he couldn't help with the clothes anymore. When's the 3rd time Tom could really safely get in and out of the shower every day, all day by himself? Oh, that was probably after the 3rd time. He hasn't done that since. Maybe a pattern is developing. And there is one developing, and it looks like this. And that last little segment, let's see, I was told I could have a fake. Aha. If you look at this segment here, the next slide, I believe, I'll come back to that in a second, just that segment. Or you can go with frailty and dementia. Those are your big choices. And this is what it will look like if you go with frailty and dementia. You'll smolder and smolder and smolder. And somewhere around here, you'll have some very well-meaning family member probably make some poor choices about aggressive care for you, and you'll spend the last 6 months with lots of unnecessary suffering. So those are the ways you get to go out. Those are the facts of death. I'm sorry. But they are the facts. This is what I wanted you to see. That last sloping segment of the cancer trajectory and the last segment of organ failure, read heart failure and COPD, are almost identical. In fact, they're so identical that is why the American College of Cardiology about 3 or 4 years ago started going to the ACC staging of heart failure rather than the New York Heart Classification, because they wanted to send the message that heart failure is a continuum, and that there is a final stage, and then the final stages of the final stage look just like the final stages of the final stages of cancer. They look exactly alike. There's this precipitous drop-off for the last 30 to 90 days, which is why 80% of people who die in this country today, yesterday, this last 10 years, who died of heart failure as their primary cause, were admitted in the 30 days prior to their death. 80% of the people in the hospitals in our country today who have heart failure today, who get discharged, will be dead in 30 days. And that's because that's what it looks like when natural death is happening. So the old model was this. Hey, you've got a life-limiting illness that's probably going to end up taking your life. You've got stage 4 heart failure. You've got advanced cancer. Let's do everything aggressive. And then if things don't go the way we hope, we can always get hospice involved at the end. And nationally, that's about 14 days. A person will get this ultra-focused type of palliative care called hospice care, where comfort and dignity and safety and all of those sorts of things are ultra-attended to, and they'll, on average, get it for about 14 days. It's a 180-day benefit. The new model that serious illness care hopes to advance is this, where we have a diagnosis of a life-limiting illness, and at that point, we start to talk about supportive care, quality of life, as well as ongoing aggressive and curative-based care. And the idea is to do this for about 24 months. And some of you say, well, how can you know if they have 24 months left? I'm very glad you asked. We'll get to that. I promise we'll circle back. I think somewhere along the way, by the way, you might have had some other fill-in-the-blanks. Not quite. All right. Just didn't want you to forget that. It's really a good little thing. So here are the official recommendations. These are the group of people who probably are not going to die suddenly and tragically, although, true story, had a lady who had terrible head and neck cancer, had the gruesome surgery, had the aggressive chemo, had the mucositis, it was really horrible, ended up getting her PEG and was doing well, left the hospital, was doing well, had her little vacation, 3 or 4 weeks, was going to come back and resume treatment. This is a true story, no kidding. On the way here, behind, not one of those sure enough industrial grade professional dump trucks, but kind of the one that Billy Bob runs, but a big dump bed on the back of a truck, came loose, came off the dump truck, landed on the car, and killed her and her husband instantly. So she actually was dying slowly and certainly and died suddenly and tragically. So you do always have the option of dying suddenly and tragically. But unless that's really the way you want to go out, you're going to go out one of these other ways. And these are the people who probably are going to do that. So you may want to take note of this. When you have these sorts of people for whom you're caring, stage C or D, by the way, stage C or D, in case you don't know, is basically structural change. They're usually people who've had an MI, but they have structural change in their heart. Left ventricular hypertrophy, chamber dilatation, wall thickening, those kinds of things. They've got structural changes in their heart. And they usually have some New York heart classification. So think somebody who's got some structural changes in their heart. COPD, stage 3 or 4. The simplest way to remember this, and Dr. Sethi, I'm sure, has told you all, if they're O2 dependent, right? If they can't take that O2 off to take their shower, they're O2 dependent, they have stage 3 or 4 disease, but arguably 4. If their pulse ox is 88% on room air at rest, you're like, well, gosh, I saw 7 of those yesterday. Yes, I know you did. That's gold stage 3 or 4. Chronic kidney disease, stage 4 or 5, which you all know about. And these are, by the way, recommendations from these academies. The American College of Cardiology recommends getting a palliative care consult at that stage. Pulmonary recommends getting a consult at that stage. The Renal Physician Association says once people hit stage 4 to 5, we should get palliative care involved because invariably we're talking about vascular access and dialysis. We should start having goals of care conversations. So these are recommendations not from the serious illness care world, but from the other academies. Cancer stage 4, the American Society of Clinical Oncology since 2010, the landmark New England Journal study has been recommending that. And then dementia debility. So these are the big ticket items. These, from moving forward in our little time that we have left together, which is not more than about 10 or 15 minutes. So if I lost you, come back. There's not a whole lot left. If I say, a seriously ill person or a person with a serious illness, this is the group of whom I'm speaking, okay? So, and there's no doubt in my mind that all of you have someone in your life today who falls into this category. So it really ends up looking like this, though. It's really sort of this waxing and waning, you know, coming and going of symptom burden, coming and going of ability to do treatment or needing treatment or wanting treatment until we reach that stage. And it's really easy, actually, to figure out those last 24 months of life. That's where the impact is. That's why you really might want to get serious illness care involved. These are the people who benefit significantly. Specialty serious illness care, which is what I do, I will tell you that primary serious illness care, also called palliative care, is actually going to be on your boards. There are going to be questions about hospice eligibility and goals of care discussions, symptom burden relief, and morphine in terminal delirium. I promise you there are. I just recertified last week. There were questions on my family medicine board, and that's because when palliative care became a specialty, about 12 other specialties endorsed it ringingly. Surgery, radiology, family medicine, psychiatry, internal medicine. By endorse, I mean, doesn't mean they just sat in a room and raised their hands and said, yes, we think that's a good idea. They said, we will put questions about that on our exams. That's what I mean by endorse, right? So there is such a thing as primary palliative care, and you're going to be expected to know it. If you don't think you know it, see me afterwards, and I'll teach it to you. Or rotate with me, and I'll teach it to you. But serious specialty palliative care is advanced training in that symptom burden relief and advanced training in complex goals of care conversations. And some of you who know me kind of know this is sort of my thing around, I really enjoy complex goals of care conversations, but I don't particularly like very first goals of care conversations, right? Nobody would consult Dr. Lambiase for abdominal pain and not have ordered a CMP, right? Nobody's going to do that. Well, you might do it once, but you won't do it again. We have a couple things teed up for him when he shows up. So, please, think about it this way. Or said another way, this is why I might not want you to get serious illness care involved. Little joke, little tongue-in-cheek there, little truth to it. So prognostication, if you don't know, is really not that difficult. Prognostication is simply about what to expect. What I really expect to happen to this person with widely metastatic stage 4 who's just had a big saddle embolus, who has, renal failure and is on 2 pressors in the ICU and they're 78 years old. I mean, what I really expect to happen? That's a good question. A researcher named Christakis, world-renowned actually, at Duke most of his career, took a look at this idea of prognostication. And he said, look, when physicians are asked, how long will this person live? And he's repeated this dozens of times over decades. When physicians are asked, how long will this person live, we will overestimate by a factor of 5, 90% of the time. So, Dr. Gersami, how long will Sally live? 6 months? 90% of the time, she'll be dead in 30 days. 90% of the time. But he also demonstrated that if you ask what's called the surprise question, you can be correct about the prognosis 70% of the time. And wouldn't you like to know what that is? Well, it's very simple. The surprise question is, would you be surprised if this person died? And he did 6, 12, and 18 months. If you ask yourself, would I be surprised? If you ask the nursing staff, if you ask the rest of the team, would you be surprised if this person died in the next 12 months? And people go, well, no, that wouldn't surprise me at all. You'll be correct 70% of the time. And 7 out of 10 times, they will probably pass away in the next 12 months. If instead you ask yourself the question, how long will they live? You'll be wrong 90% of the time by a factor of 5. And you'll do something like this. You'll say, oh, Sally, we have plenty of time. I think you'll live a good 2 or 3 more years. And in about 4 months, Sally will be dead. And then you'll be one of those physicians who people say, gosh, I think that person, by recommending some other things, took some quality and quantity from me and my family, and nobody wants to be that person. Well, that's a reason you might want to think about getting serious illness care involved. You might think, some people think I actually have a real lightsaber, and then I can tell people these are not the droids you're looking for. And they may be right. I may actually have a lightsaber. Some people think that I might have something else. So, don't you love this guy? Ah, we meet again. Well, who do we meet again? We meet these people, all right? So these people, you should ask yourself, would I be surprised if they died in the next 12 months? Here are 3 big clues in case you can't get yourself to tell yourself whether or not you would expect that. Here are 3 really big clues. People with those conditions, all right, these people, these serious illness folks. 3 big clues. If there is an increasing utilization of healthcare resources, read, more than one admission in the last 90 to 120 days for the same or similar illness. That's an increasing utilization of healthcare resources. And you're thinking, what about 5 admissions in the last 5 months for the same or similar illness? Yes, that's increasing utilization of healthcare resources. That is a huge clue that this person may be dying. Unintended weight loss of greater than 10% of their body weight. Gosh, I see that happen a lot. Yes, that's a big clue that people with those illnesses that I listed are more in the dying phase than in the living phase of their life. And a decline in their performance status. And we'll explode this just a little bit. Don't get overwhelmed. But this is where some people have accused me of having a crystal ball. But for those of you who've chosen to get up early and come this morning, I'm going to share. We're talking about what to expect. Here's what you can expect to happen. You can expect that group of people who have those 3 big clues, half of them will be dead in 5 years. 85% of them, there's an 85% chance of all-cause mortality in any 2-year period for them. So that clock is sort of perpetually ticking. And there is a 0% chance that those people with those conditions who have those losing weight, losing function, increasing utilization, there's a 0% chance that they will be more vigorous, more healthy, more vital 2 years from now. Okay? So, the crystal ball that everybody is wondering, can we peer into your crystal ball? Yes, you can. My crystal ball is the Palliative Performance Scale. Don't panic about this slide. I'll break it down for you. This is a validated metric in the literature. It's literally internationally validated. Some of you have seen how powerful sodium can be at predicting mortality. A sodium of 109 is very concerning for you. A sodium of 189 is very concerning for you. You've seen people with an albumin of 1.2 not do very well. Or a white count of 400 or 400,000 not do well. We know that those things predict morbidity and mortality. The Palliative Performance Scale has been compared head-to-head with each one of those, head-to-head with all 3 combined, multiple times around the globe, and found to be significantly more predictive of morbidity and mortality. This is the most powerful tool at predicting morbidity and mortality, so powerful that there is actually a digital crystal ball called ePrognosis. I don't know if it's an actual app, but you can look it up, ePrognosis, and it will actually let you plug in patient data, and it will spit out, here's what you can expect on a time frame for this person. That's how validated this is. There's an app for it now, okay? I told you I was going to break it down for you. Here's really the hard cutoff point. This PPS of 30% down here, 30 to 40%, this is what it looks like. This is what the human being looks like if they're Palliative Performance Scale. Now remember, we're talking about the people who have 1 or more of those significant serious illnesses. Always remember that, okay? They're mostly sitting or lying. They're unable to do any work. They may be able to totter around the house, but they really can't help wash the dishes and load the dishwasher. That's actual work. They really cannot do that on an ongoing, regular basis. Okay? They're mostly dependent on others for care. They have to have help getting in and out of the shower. They really have to have help someone doing their clothes. They have a reduced intake. Well, you know, she's just kind of lost her appetite lately. And they have a normal to reduced consciousness. When our friends, we meet again. When our friends here have a PPS in the 30 to 40% range, and this is the mind-blowing slide. So if I lost you, come back, because this really is important that you see this for your own well-being. Here's what happens. If you have one or more of those 5 conditions and your functional status is declining and you hit the 30 to 40% range, you have a 6-month mortality of 89%, all-cause mortality. And I mean all-cause, right? If they're in a car wreck, if they get pneumonia, if they fall down the stairs, if they get, you fill in the blank, they have no margin, no reserve at all. They will not survive one more tipping point. Not necessarily the disease, right? It's usually related to the disease, but if they have anything, they have no reserve, and it will take their life, 89%. But look at their survival in days. The median survival in days is somewhere between 10 and 41 days. So somewhere between 30 and 40% performance status. And you have one of those 5 illnesses. You have a median survival of, wait for it, 25 days. I don't know if I mentioned to you that 80% of people who die of heart failure die in the 30 days after their most recent admission to a hospital. So, we're getting very near the end. We only have a few more slides. Ashley's going to pass out. Is she still here? Is my friend still here? Yay! She's going to pass out another worksheet. There's a few more on your kindergarten worksheet, a few more answers coming. So be sure to fill those out. It's your choice, but you'll be glad you did, I promise, and I'll tell you why when we're done. This one she's going to pass out face down. Please, class, leave it face down until you're instructed to turn it face up. And when you turn it face up, there's going to be a series of questions. Kindly take your kindergarten sheet and cover the subsequent questions and only look at one question at a time as I walk you through it. You'll be glad you did, and so will I if you obey. Thank you. So, sad but true, right? We really don't want to do this, but we do. I do this. It's just the way the world works. So if we're going to try to not do that, then we're going to try to figure out why we want to get serious illness care involved. By the way, if you give somebody a PPS of 30 to 40%, that's the time to think about that particular nuance, that small expression of serious illness care called hospice care. Specialty outpatient palliative care is not going to help them at all. So if you give somebody a PPS of 30 to 40%, please already be thinking, I need to figure out how to start having a goals of care, maybe a hospice conversation with this person. If it gets complex, feel free to invite me in. In other words, the patients that you really might benefit from getting serious illness care involved are people with a PPS of 50% or greater who have one of those significant illnesses. So we're going to help those with life-limiting or life-threatening illnesses live meaningfully longer. I think this is one of your fill-in-the-blanks. Meaningfully longer than age-matched controls, and it will dramatically reduce the cost of care. Want proof? Okay. Here's the increased length of life. If you have age-matched controlled, everything else is equal, and they have lung cancer, and they either get serious illness care involved or they don't, they'll live 120 days longer. So that was the landmark study in 2010 in the New England Journal that found that non-small cell lived 4 months longer. No treatment difference, no variable difference, no age, no sex, no disease burden difference, just by having a supportive palliative care team involved. Patients with heart failure will live 81 days longer. That's a long time, folks. That's time enough for a first child to graduate from college, or a first great-grandchild to be born, or a 50th anniversary to roll around. Lots of meaningful things can happen in 81 days. And they get that just by having this added layer of support on top of their ongoing aggressive care. Cost reduction? If you get that group of people and you can get them involved in those last 24 months of life with your serious illness care team, here's what they can expect. They can expect a 50% reduction in the amount of time they'll spend in the hospital in the last 2 years of their life. Half. They'll spend half of the rest of their life less in the hospital than they would have otherwise spent. Now that is something worth going for. Those of you who have to work in the ICU, some of you people actually like to work in the ICU, are going to be professional ICU people. It boggles my mind. But there's got to be days when you think, I'm not so sure this person needs to be in the ICU again. If you get serious illness care involved with our top 5 hitters, somewhere in the last 24 months of their life, you can expect an 85% reduction in the amount of time they will spend in the ICU. Now, please, somebody show me something in medicine that has an 85% reduction of a negative outcome. I'd like to see it. By the way, it's free. All right, this is a Medicare. This is not extra. This is not expensive. It's a basic consult. You'll have a 60% decrease in unwanted readmissions. 60%. I mean, we're excited when we have a 4% reduction in readmissions for heart failure, COPD. If you get serious illness care involved with those people when they have a gold stage 3 or 4, pulse ox of 88% on room air at rest, ding. Get serious illness care involved, you can expect them to have 60% reduction in their unwanted readmissions. And if they do get admitted, you'll save about $7 grand per hospital admission. Yump and yiminy. That's a lot of money, particularly since that's the cohort that typically gets admitted, right? So I think we've filled out all your blanks on your kindergarten. I think we have one more slide, and like I said, we're going to be getting out a little early, but don't turn over your green page yet. Don't turn it over yet. This is my last little quote. One of my favorite authors. I really like the way he could turn a phrase. I mean, you know, in my personal life a week ago, I was like, just take me now, God. I mean, really, I was crying out. I'm done. I'm over. I'm through. I mean, I have a wonderful life. What was I complaining about? But there I was, driving home. I was complaining. It was hard to live, you know. And then I come to work and I go, boy, how hard it is to die. Yes, what a strange thing for me to say. Just yesterday I was saying how hard it is to live. All true. So you've got your kindergarten page. Let me go ahead and tell you why you filled in those blanks. It's because you're adult learners. And adult learners have learned just about all of the tricks to keep themselves from learning. Unless they do one of two things. And there's a whole science behind this. You either have to raise your tension. You have to make it stressful environment. Read residency. Or you have to sneak up on yourself. And there's a whole part of your brain that learns and listens and remembers and recalls if you write something down when you see it. But if I had told you that early, you wouldn't have snuck up on yourself. But you did if you filled in your blanks. You are going to actually be able to recall what you heard today at a much deeper level for a much longer period of time. Kindergarten is a good time of life. So take your kindergarten paper, turn your green page over and cover everything but question number 1. This will take about 5 minutes. This is mostly for me, but it's also for you because this is anonymous. If you were willing to, I would appreciate you leaving it with Ashley on the way out. I believe the first question you have there is, now, having heard what you heard, in a sentence or two, just in your own words, write down why you might get serious illness care involved. Why you might. Based on what you've heard today, the first thing that comes to your mind, why you might. Just might, maybe. One day, possibly if I ever, why might I be interested in getting my serious illness care team involved? Shouldn't be more than a sentence or two. This is really cool neuroscience. This is like 2 decades of, this is Michael Pantalon, by the way, John, at Yale. It's a really cool thing, and I'll explain it a little bit when we're done. All right, you can go to question 2 now. Don't go to question 3, promise, trust me. Go to question 2. On a scale of 1 to 10, with 1 being not likely at all to get serious illness and care involved, and 10 being very likely, where are you? Are you a 2? Are you a 7? Based on what you heard, what you think about your own practice, why you might get them involved, where are you on that scale of motivation? Little motivated, sort of motivated, highly motivated. So that should be an easy number to write down. Once you've written it down, we'll slide down to question number 3. Why didn't you pick a lower number? Not a higher number. Why didn't you pick a lower number than the number you picked? And really, write down what came to your mind. Why didn't I pick a lower number than what I picked? If I picked a 5, why didn't I pick a lower number? Thank you all for your kind participation. This is very gratifying to see you working on this. I've been tasked with helping Erlanger develop a serious illness care program, which is a little bit like inventing the wheel. So that's the way I feel some days. Your feedback is going to really help me, but it's also going to help you, and I'll tell you why when we're done. Next question. If you could snap your fingers and magically that need, well, if this were going on, this is why I might get serious illness care involved. If you could snap your fingers and suddenly that need got met by the serious illness care consult that you placed, what's in it for you? What does that do for you? In your personal life, in your professional life, in your family life, in your emotional life, whatever. What does that do for you if that problem gets solved by that consult? And what actually happens for you? Not for society, unless that's what's most important to you. What really happens for you? Totally anonymous. No one will see this. Probably I'll be the only one who actually reads them. I forgot to ask you to write legibly. So if you haven't done that yet, please start writing legibly. Only 2 more questions to go, and we're 20 minutes ahead of schedule. I mean, come on, who gets you out of here 20 minutes ahead of schedule? All right, question number 5. That thing that you said was valuable to you, why? Why is that important to you? Well, if I got serious illness care involved, it might lift the burden of some time constraints on me today, and I might be able to actually pick the kids up from ballet this time rather than having to call my spouse and say, I'm sorry, I can't get to ballet again. I can't do it. Well, if that's the 52nd time you've done that this year, it might have a lot of value to call and go, bro, I'm on my way. I'm out. I'm like 15 minutes ahead of. I'm at ballet. How you like me now? Yeah, I can pick them up. I'm here watching them. Shoot a video. Ding. Yeah. Oh, yeah, I'll get them at ballet. I'm here. Why? Why does what you think would be a good thing matter to you? Why? Why does that help you? And since it's anonymous, you can be as transparent as you want. You can write down the real reason that helps you. Because, by the way, why is why. If you can figure out why something matters to you, you've figured out how to do it and what to do. So spend some time figuring out your why in life, by the way. Question number 6. Now, having done that, what, if any, is the next step you need to take to start getting serious illness care involved in your practice, with your patients, in your hospital, in your community? What's the next step, if any? There may not be anything that you need or want to do, but based on what you've heard, based on these questions you've asked yourself, what's the next step, if any, what you might need or want to do? And then I just have about 60 more seconds after you finish that to explain what you just did. You probably know about this, Mike, do you? Do you know about this work, Instant Influence by Michael Pantalon? It's a terrific thing. So you may actually want to, by the way. This is the Cliff Notes of a book called Instant Influence by Michael Pantalon, Pantalon. PhD? Yes, he's a clinical psychologist, PhD. At Yale, this comes from decades of research. The first 2 chapters of the book lay out some of that research, which is mind-boggling to think about where they were doing the research. They were doing it in emergency rooms and in surgical suites and in prisons and unbelievable places they were doing this research. So what you just did was help me. Thank you very much. But you also did the ultimate sneak up on yourself. You just peeked behind the curtain to see who the wizard really is back there who's running this show. And here's why. Our beliefs drive our behaviors. every single thing you do every day, all day long, every action that you take has a belief behind it. If there's something going on in your life that you wish you did differently, you will not ever do it differently until you figure out why you do it that way. What is the motivation behind why I do it that way? And if you can figure out what the motivation would be for why you might do it differently one day, whole circuits turn on in your brain that weren't turned on before that start trying to figure out how to help you behave differently. But you will never behave differently until you figure out your motivation. And more importantly, even the smallest amount of motivation is orders of magnitude stronger at helping you or someone you care about change than focusing on every single reason why not to. Which is where we spend most of our time when we talk to ourselves, our loved ones, and our patients. Well, you know, if you don't stop smoking, you're going to get lung cancer. Well, if you don't wear your seatbelt, you're going to die in a car wreck. Well, if you don't make good grades, you won't go to good college. Well, if you don't wear a condom, you're going to get STDs. Well, if you don't, go to the ball game with me tonight, I won't go to the dance with you. Those are all reasons why somebody would not want to change. But finding out why they might want to change, what's their motivation, is what actually causes you and people you love, and even people you don't love, to change for the better. So congratulations on sneaking up on yourself, finding out your motivation. You can leave those on the way out. I'm happy to entertain some questions because we do have some extra time, Lou. We have time for questions if anybody wants, but don't feel obligated. You've got important things to do. So if you have questions, I'm happy to talk. Yes, ma'am.
I don't have a question, but I do have a testimonial. I've been privileged as a hospital chaplain to be working in Dr. Johnson's office with Chris Dominguez. He's one of the nurse practitioners there. And I see the amount of time and care that they get and the amount of compassion and the relationships that develop with them. And I think that spiritual side that I can help provide, but also they do in terms of the care of patients means so much to them as well. There's really a relationship there that is established that's very important. With that.
Thank you very much. Dr. Saba tells me all the time, look, people don't make decisions based on information. They make them based on relationships. Try to cultivate a relationship with these people, please, and then download your information. That's a good suggestion you made. I'll try to remember it. Anyone else? Yes, sir.
Yeah, you talked about all few illnesses.
Yes.
Cancer.
Yes.
We are getting a lot of stroke patients.
Yep.
What is the role of palliative care?
That's a good question. I think I would defer to Dr. Devlin, who runs the Stroke Universe, or Donna Borden, who runs the outcomes that the hospital is interested in. But remember that if their PPS is less than 30% and they've had a stroke that's put them in there, and we're 15, 21, 28 days out and we're no better, hospice is what you want to be thinking about. If, on the other hand, everyone thinks there's a meaningful chance of some recovery, but not completely back to where they were, and we're talking about rehab, and we're also having neuropathy or agitation or those kinds of things, serious illness care in the hospital can really help that and can help to figure out what do we really expect to happen over the weeks and months ahead so that families and patients can start making choices that best align with their care. For example, it's not uncommon to have someone who's had a stroke who lives a significant different distance from here, 100 miles, right, from Spring City or Ray County. And we're talking about putting that loved one in a nursing home here or a rehab here, and their 68-year-old spouse who doesn't see or drive very well anyways, how am I going to get here, and the transportation, and all that starts to happen so we can have larger conversations about what's really practical, what really meets your needs and values the most. Maybe we can just go to a nursing home near you and get so-so rehab, but you're near one another and you can spend time together, because that might be more important than Siskin an hour and a half away for the next 6 weeks, and they died during that time, right? So, does that answer your question? It's at the end of the day, it's up to you. If you have a patient who's had a stroke and you want to get a serious illness care opinion, just click the button, and we will come. Yes, ma'am. Yeah, that's a good question. I think, I'm so sorry. She has patients at the Dodson Clinic who have little or no resources. How do they access our care? I think you just refer them, frankly, and we see them just like you do. And because we're an Erlanger-owned program and it's a community-based hospital, there's a built-in understanding that some segment of our population will be that. No one is denied access to us based on that. Now, I may run into the same problem with medicines that you do. Things I might prescribe just may not, I can't do anything about that. But no one is turned down. So if you have someone who doesn't have access to insurance or something like that, that doesn't mean they don't have access to serious illness care here at Erlanger. Yes, sir.
Palliative care has moved in the last few years as a system recognized. But my question is, we've got a lot of new drugs that are very effective even in late-stage cancer now with the checkpoint inhibitors, etc. Do you see any attempt to not just look at survival, but quality of justice, survival is the outcomes for all these trials that you do?
Yes. Yeah. So for those of you who didn't hear the question, we've got some new, really helpful pharmacology in our world that is shifting the natural course of illnesses. Stage 4 cancer that responds to immunotherapy was his example. And the question was, well, does that start to change the curve? What do we start to do about that? And the answer from the academic mothership of palliative care called the Center to Advance Palliative Care is get serious illness care involved, and this is actually really important. It's a lovely question. Get serious illness care involved based on the diagnosis, not the prognosis, because we are about quality of life during the entire course of the serious illness. So maybe this person with stage 4 is going to live 18 months longer than this immunotherapy, but they may also have a whole new batch of symptoms that come along with this new pharmacology, or a whole new batch of things that pop up in their life that they can deal with now that they couldn't deal with, and that's where chaplain support, social work support, nurse practitioner support, the team approach continues to support their quality of life during whatever length their illness may be. So the idea is perfect. Please think about getting serious illness care involved based on diagnosis, not prognosis. My point in the prognosis was that's a real thing that lands in your lap on a regular basis. And if you want to have a pretty strong sense of what to expect, whether or not this person, new therapy or not, is likely to survive this illness, you can watch their functional status, and it will lead you right to the outcome. Okay? Thank you, Dr. Sethi. Anyone else? Yes, sir. No? Good? Okay. Really, thank you for your time.